So good evening, everybody. Greetings from WOFAPS. We have with us today the president of WOFAPS, Professor Alp Numanoglu. He's a professor of pediatric surgery. He practices at the Red Cross Hospital at Cape Town in South Africa. Welcome, Professor Alp.
Hi, good morning, good afternoon, Professor Sharma, and good afternoon to everybody.
It's very nice to have you with us today. So would you please tell us what is WOFAPS and what is the World Pediatric Surgery Day about?
Thanks very much for the question, and thanks very much for having me here today. It's really a great privilege and honor for us to host this event and talk about WOFAPS and World Pediatric Surgery Day. WOFAPS stands for the World Federation of Associations of Pediatric Surgeons. So it is a global entity. And as we all know, each country have their own pediatric surgical association, a national association. And more than 100 of them are under the umbrella of WOFAPS Federation. So they're members of WOFAPS, the main WOFAPS body. WOFAPS has been going on for a long time, and in fact, it started in 1974. This year, in 2024, we're celebrating our 50th year, and it's the body that encourages the colleagues to become pediatric surgeons. It advocates for pediatric surgery, and at the end, obviously, the end goal is to help the patients and with pediatric surgical conditions. Every 3 years, WOFAPS has a World Congress, and our next Congress is going to be in Turkey in November next year. So we're looking forward to that meeting where many pediatric surgeons from all over the world come and join together, and they present a new research that takes place in our field, as well as discuss problems that they're experiencing. So with that in mind, and with that advocacy duty and responsibility that WOFAPS has in mind, we wanted to celebrate a day as the Pediatric Surgery Day, as World Pediatric Surgery Day, and the 7th of April has been chosen for this. It is an important day in the history of pediatric surgery, the 7th of April, and that's when the Kyoto Declaration has been signed and made available. Kyoto Declaration talks to basically what pediatric surgery is and what pediatric surgical conditions are, and also why pediatric surgical conditions should be treated by pediatric surgeons, and that's one of the main foundations of WOFAPS as well. So it is a big day for us. It's the inaugural year this year in 2024, and my colleagues in the WOFAPS executive unanimously agreed with this decision, and they've initiated this thing, and we can already see in many platforms that colleagues are celebrating this day in many continents. It's from Africa to Asia to Latin America to Europe, North America, as well as the Australasia. So it's been a big event for us.
It's wonderful. So it's kind of a global initiative to promote surgical health in children. So
absolutely.
What is the age group in which you describe children for surgery? Is it different in different countries, or what is the upper age limit?
Yeah, so there are differences, but I think the starting age remains the same for all pediatric surgeons. Mm-hmm. So pediatric surgeons start from day one of life, and in fact, in many instances, they get consulted by obstetrician colleagues when antenatally a diagnosis is made, but caring the child starts in some areas, perhaps in the fetal life as well, but practically in many countries from day one. When we say day one, it might also be, of course, a premature baby going down to 500 grams at birth, but usually slightly bigger than that in many countries. And then the upper age changes. Certain countries take as 13, 14, so perhaps a little bit younger age. Most countries, pediatric surgeons will treat up to the age of 18, and in some countries up to the age of 21. The patients are regarded as pediatric cases. The one other aspect we must not forget, of course, when we're treating congenital malformations, it's not always a condition that can be cured within that age frame. So the treatment continues long into adulthood as well, in collaboration with our adult surgical and medical colleagues.
That's quite a lot of devotion for the child, because since the child is born and then he grows up into adulthood, he is being followed up by a pediatric surgeon so that he has good functionality and acts like a good human being, healthy and functional as well. We have with us Professor Amadeo Zanotti. Welcome, Professor Amadeo. Are you online? He's the Vice President of the WOFAPS. Welcome, Professor Hector. Are you there? He's from South Africa.
Yes, good morning. Thank you very much. And hello, Alp and Hector. I'm participating of this interesting meeting, yes, and celebrating the 7th of April as the Pediatric Surgery World Day. Thank you, Shilpa.
So in Paraguay, what is the upper age limit? Is it different in different hospitals? The upper age limit for pediatric surgery?
No, we operate until the age of 18, which is end of adolescence.
So the WHO describes it as 0 to 18 years. In India,
Yeah.
Some hospitals are still stuck with 12 years. Some go up to 14. And then those who have facilities for more pediatric surgeons start taking up to 18 years. So Can I ask you a question? What are the common congenital anomalies that you see as a pediatric surgeon?
Anorectal anomalies. We see in Paraguay, as the literature described, the whole game of different situations of anorectal anomalies. We are prepared, and we are operating in private institutions and public institutions as well. And because the whole country is not covered by pediatric surgeons, but we try to refer to concentrate these anomalies in hospitals that have pediatric surgery facilities. From the little anus sighted to the cloaca, we have all seen in the whole range of malformations. The difficulty is to do the diagnosis prenatally, and it is always, most of the time, made postnatally. But we are not trying. Most of the time, we do the colostomy first, and then do the reparation or surgery of anorectal malformation most of the time. Very few patients we did operations of anorectoplasty at birth without colostomy. But I personally don't prefer that. I usually do the colostomy first and then take my time to repair the malformation.
Welcome, Professor Cenk Buyukunal. Yeah, Professor Alp.
I think, as Professor Zanotti mentioned, and he's our Latin America representative and vice president, as you mentioned, in WOFAPS. The congenital abnormality is one big field that pediatric surgeons deal with today. But perhaps we have other major disease burdens that pediatric surgeons deal too, in addition to spending a lot of time dealing with congenital abnormalities. One of them is the trauma, because that is one of the biggest killers, unfortunately, still today in many lower and middle income countries. And pediatric surgeons deal with the pediatric trauma in that age group. And then the other conditions like burns is still a major burden of disease in many lower and middle countries that pediatric surgeons deal with. So it is, in a sense, a highly specialized field, but on the other side, it has a very big public health component as well. Thank you.
Welcome, Professor Buyukunal. Would you like to throw some light on the cancers that are seen in children?
Not now, not now.
Not now?
Shilpa.
Okay. Yeah, Professor Zanotti.
I wanted to add a little comment. That I think most of the congenital malformations justify the origin of pediatric surgery, but specifically talking about the anorectal malformation is one of the malformations that if you don't treat it appropriately at the time, appropriate time, probably will be an adult with very severe sequelae. And if you do the right treatment according to our training, probably will be an adult without, with a normal life. So we need to follow them up for a long time. And that is the main issue of pediatric surgery. We treat the patients prenatally, neonatally, and for a long time on development.
So when we talk about surgical specialties, the layman wants to know where pediatric surgeons draw their boundaries. So like heart disease, do they do heart disease still? Brain surgery and clubfoot. Clubfoot is a very common congenital anomaly picked up by the WHO also. So that also we have given up for the orthopedicians. What is the condition? What are these conditions? How are they dealt with in your country? By pediatric surgeons or by cardiothoracic surgeons, neurosurgeons, and orthopedic surgeons, respectively?
No, in my country, neurosurgeons do all the neurosurgery, including the myelomeningocele.
Okay.
The pediatric cardiac surgeons do the cardiac surgery, and the clubfoot is attended by the orthopedic surgeons, pediatric orthopedic surgeons. There are very few of them.
In India, the meningomyelocele and hydrocephalus was quite a lot done by the pediatric surgeons. It is now that the neurosurgeons have started doing it, but they take children more than 1 year of age. So little children, when they come in the newborn phase, they are mostly dealt with by the pediatric surgeons. How is it in South Africa, Professor Alp?
In my age, sorry, sorry, just
please go ahead.
An interruption. In my age of training, I did the myelomeningocele in South Africa. I trained in Durban. I operated many of myelomeningocele, but when I came back to Paraguay, the neurological anomalies were attended already at that time by the neurosurgeons. So it was very hard to me to continue doing myelomeningocele. So I lost that field.
So if I can, thanks very much, Amadeo. So if I can try to answer your question, Prof. Sharma, from South Africa point of view, I think, as we mentioned, the WOFAPS is now celebrating its 50th year. Having said that, pediatric surgery is fairly a new specialty if you compare it with other surgical specialties like orthopedics and obstetrics and gynecology and so on. And pediatric surgery has gone through the same sort of development phase and changes like other surgical specialties, and particularly perhaps the general surgery has gone through. So in the past, a pediatric surgeon could be seen treating conditions like meningomyelocele and cardiac diseases perhaps as well. But today, every area is specialized on its own. And also in South Africa, that's the case now. So cardiac surgery is done by pediatric cardiac surgeons. Myelomeningocele and hydrocephalus is done by pediatric neurosurgeons, and likewise. So it is an evolution process, and that's taken place in South Africa as well. So every specialty has got their role to play in a very good way, of course.
What about pediatric urology, the posterior urethral valves which present in the newborn age? Who deals with them? The pediatric surgeon, or have you divided into pediatric urology and pediatric surgeon? Or at some places, the pediatric surgeons with special interests in pediatric urology?
Not in Paraguay. We are not divided yet. Most of us pediatric surgeons deal with the urologic conditions. I do a lot of patients with urologic conditions like reflexes, hydronephrosis, PAUJ obstructions, and we do the treatment of this.
How is
You
the
listen to me?
Yeah, Hector.
Shilpa?
Welcome, Hector. Welcome. How are you?
Oh no, I listen you, but I don't connection my voice and my imagine. Good morning for all. I'm happy for having suggest in my first meeting that I participate in WOFAPS April 7 as World Pediatric Surgery Day.
Yes.
In my country, 90% of surgery in children have for pediatric surgeon. Exclusively the emergency with the pediatric surgeon is not stay in this moment. The surgeon, the general surgeon, participate, but 90% of the surgery in children is have the release the for pediatric surgeons. The age of the surgery in my country is the born and 15 yes, the 15 age, but in oncology is at the 18 age. I have surgery, malformation, urology, have a urologist, a cardiologist, a neurosurgeon for children. I release laparoscopic surgery, have a robotic, but in this moment, no have robotic for children's. In oncology, have a sequentiator, have a molecular biology, my country have it's similar to the countries for Europe. Have operate malformations, anorectal, Hirschsprungs, all the pediatric surgery, and thoracic malformation, pectus. I promote the oncology and the thorax in my country. I integrate my country integrate WOFAPS obviously, and integrate Stipes Sur
Yeah, super.
Yes.
Very nice.
No more comments. No more comments.
Very nice. So most pediatric surgeons do everything from head to toe, and only little things are missing, which we have to give them because they do a better work: cardiothoracic surgery and brain surgery. Meningomyelocele is different in different countries, and pediatric urology has remained a part of pediatric surgery in many of our developing countries at least. And it was also a part in UK. It's only now recently that they have separated. USA was the first one to separate pediatric surgery and pediatric urology. Yes, Professor Alp, you want to say something?
Thanks very much. So I just would like to acknowledge at this point the important collaboration that we have with our colleagues in fields that are certainly in surgical specialties, but also outside as well. A lot of developments that took place. Again, I'll go back to that 50 years that WOFAPS has been around, and pediatric surgery has been around a little bit longer than that, of course. But things like pediatric anesthetics has developed so much over these years that made it possible for pediatric surgery also to enhance. Pediatric intensive care unit has developed so much that made pediatric surgeons to operate on more difficult cases and more complex cases. And nursing is one big component that we have to acknowledge the improvements that's taken place that made it possible for the cases to be cared for before and after the operation. So I think we're all playing a very significant role in our fields that's making the surgery for children to be successful as it is today. Thank you.
Definitely. So we'd like to know about common. You want to say something, Professor Amadeo?
Yes, just to remark what Professor Alp is saying, that all these developments are or were developed because of the needs of the surgical patients. So they needed special anesthetists, and they developed the pediatric anesthesiologists. They needed intensive care units for post-operative care, and the intensive care units were developed accordingly to treat neonates. So, and even more, prematures, very small prematures are surviving because of these facilities. Very, very good comment, Professor Alp.
Definitely. We need lots of more pediatric anesthesiologists. They are not available in all hospitals across the country, but most big hospitals have them. But the ones in the villages and periphery are still managing with general anesthetists who are trying to do the pediatric anesthetist work. They are learning in their own way. But yes, it's a special field and requires a lot. Cenk, you want to say something?
Well, yes, couple of words. For Turkey, there is a rule from Ministry of Health. If there is a pediatric surgeon in that region, city or town, the children under 18 years of age should be operated by only pediatric surgeons. And this is especially true for the private insurance issues as well. They want the children to be operated by pediatric surgeons. But as you mentioned, the brain surgery or neurosurgical procedures are done by pediatric neurosurgeons, and orthopedic issues done by pediatric orthopedic surgeons. There was a big problem as far as urology is concerned in my country. There was a big argument between those coming from adult urology basis or coming from pediatric surgery basis. Mm-hmm. Now we have a peace between two specialties, and but the majority of pediatric urology operations are done by pediatric surgeons in our country. I would like to mention about subspecialty in Turkey. big institutions, only the big institutions, major institutions, like in Istanbul, Izmir, and Ankara, they have subspecializations. I have to mention that Alp's father, Professor İhsan Numanoglu, he was the first man in Turkey who encouraged his team for subspecialization, and subspecialization began in Izmir, thoracic surgery, pediatric urology, and pediatric plastic surgery, and also the burns. Especially burns become a major unit in Izmir, Professor Numanoglu's unit. For the time being, I would like to mention only these things, and especially the development of pediatric surgery is very much connected with the development of pediatric anesthesiology, as Alp mentioned. The development of pediatric anesthesiology was another evaluation in our history, and now we are much more safe with the expertise pediatric anesthesiologists. Thank you. This is all I would like to mention for the time being.
The newborns require a lot of care. So in our country, when pediatric surgery started developing, a need was felt to make a neonatal surgical ICU, which is still there and being managed by us as pediatric surgeons, because we think our trainees should learn how to manage the surgical care of newborns. But when they go out into the private sector, the neonatologists look after them. So there must be a drastic care between the neonatologist care being supervised by the pediatric surgeon, where some clashes may take place with the treatment, vis-a-vis only surgical trainees looking after the pediatric surgical neonatal ICU. What is your opinion in that? And do anybody else, any trainees outside our country, look after the neonatal ICUs themselves, or give it up to the neonatologists completely?
Shilpa,
yes.
In my country, the surgery, the newborn surgery, emergency surgery, have the hospital have operate room exclusively for operate the newborns.
Mm-hmm.
In my country, the first step for surgery of newborns and others is the hospital, Pereira Rosell. The private is a level inferior level respect at the hospital. The first level have in the hospital. In the private is it's not good, the surgery of newborn. Thank you.
Alp, how do they do it in South Africa?
Shilpa, sorry, sorry for my Cherokee. It's no, I don't speak in English. I speak in Cherokee.
We can understand you completely. Don't worry. Thank you for your participation. We can understand you.
Thank you.
Yes, Professor Alp, how do you manage in South Africa?
I think we've also seen a change in that, and I can talk about sort of late 1990s and early 2000, but certainly late 1990s in South Africa, and predominantly, of course, in Cape Town, where I've trained and I've been based since then. The neonatal surgical intensive care unit in those years was managed by the pediatric surgeons, and both the surgery was done by pediatric surgeons, and then the care of the neonate in the intensive care unit with full intensive care unit management. And when I say full intensive care unit management, I mean the ventilatory care and everything else that comes with it is all managed by pediatric surgeons. This is late 1990s. And then in early 2000s, there's been a change, and we had more pediatricians and neonatologists and taking charge of those areas. And today it is managed and run by our colleagues from pediatrics, the intensive care unit part of the management. And the surgeries, of course, are continued to be performed by the pediatric surgeons. And there's a collaboration. So we work together and we manage the patients together, but the actual care in the unit, in the intensive care unit today, is provided by the neonatologists and pediatricians in that area. And there's been a change. I must say it's been a positive change for us. The one aspect that you have mentioned around training, I do feel that there can be more work done on that from the pediatric surgeons training in the postoperative care of the children and in this case the neonates. Obviously, if they're involved in that environment as part of the team, they do receive a higher intensity training, and that's an area I hear your concerns, perhaps, if I can word it that way. That more work can be done.
Yeah, so I think from WOFAP's point of view, we should develop a guideline on how the neonatal care for each condition should be done, what the pediatric surgeon has to do, because if you get cases like tracheoesophageal fistula, it will be a resident from pediatric surgery who will be able to diagnose it and take it for the X-ray examination with the red rubber catheter. On the other hand, if we leave it completely to the neonatologists, in some setups, they take only inborn babies. So if we had left it to them, we would not have got to see so many babies which are born outside the hospital, because they don't take outborn babies because it causes more infection and NEC. It's just hospital protocols. When they have less beds, they start with inborn nurseries. And when they have more beds, they expand to taking babies from outside with transfer.
So I think every country and every unit has got their nuances, and we, as we're discussing now, we're also seeing that the practices are perhaps different in different regions, different countries, and even within the same country, there are differences. I think it's wonderful to have an opportunity like this to discuss the differences in a perhaps more. Also, we're taking this to our congresses as well, and that's more where the scientific discussions do take place. And to identify what would be the best care for the children in that condition, who should be caring them, and so on. So that's again a process that's in evaluation, and again, every country, every unit, they have their best practices. We touched a little bit about urology. I don't want to go back to the urology again, but one of the things, of course, that's happening is both urologists and the pediatric surgeons, they do train on the conditions of pediatric urological diseases, and they all familiarize themselves in at least the emergency management of the conditions. We probably won't have time to touch on specific conditions today too much, but one of them that we thought maybe we can talk about is the posterior urethral valves. I think everybody in these surgical fields needs to know the management of the posterior urethral valve in an emergency setting, and that's the life-saving part of it, and to start with. And then in your area, wherever you identify as the unit or as the person, as the area best able to care for that condition, then the patient is transferred there. But the emergency management should be initiated by a competent surgeon. And I'm glad to say that the colleagues are training in that, regardless of which surgical specialty they come. And in this specific case, obviously, we're talking about urology and pediatric surgery.
That's a very good take-home message for us, because our urologists do not have rotation postings in pediatric surgery to look at pediatric urology cases. If they get that, they will be much educated for posterior urethral valve, at least, which is an emergency condition, life-threatening condition, which may go up to metabolic acidosis, needing ventilation. So they should know about that. Talking about newborns, I'll move to Professor Amadeo. Suppose a colostomy is done in a newborn. How would you manage the colostomy? What will you say to the layman? Suppose you're talking to a mother and you're discharging the patient. How should she take care of a colostomy that is an opening of a bowel on the abdomen for anorectal formation?
Yes. I have seen the ingenious development of the mothers. Surprised, and because every mother has the own way of cleaning the colostomies. We had problems with the colostomy bags to apply for a newborn. They always end up dislodged, and it's very difficult to maintain. So most of them treat with nappies on the colostomy, and I've seen many devices developed by the mothers to hold the nappies around the colostomies, and the colostomy skin, the stomach skin, are perfect. I'm surprised, and I always and every time I learned something new from the mothers. I always treating on Hirschsprungs, perhaps. I do the colostomy on the right hepatic, the transverse on the right angle, hepatic angle. Try to have enough colon left to do the descent. And on anorectal malformations, I do the sigmoid colostomy, and when I tried the anorectoplasty, then I close the colostomy, and the whole process take me about a year and a half, 18 months, most of the time. And for all that time, we are in touch with and very close contact with the families. And I learned a lot from the mothers.
May I comment on this issue?
Definitely.
Well, this is a story about early 80s in Turkey. We had a problem, especially those cases who are coming from underdeveloped side of country, especially southeast of Turkey. And we have some immigrants from that region, from other Arabic countries. If there was a baby with colostomy, and if we sent a baby to home, we experienced the death of child very soon. There was a severe neglecting and, not giving care for the babies. In some regions of Turkey, they believe that a child with colostomy is not a good thing for the harvest or the productivity of the country. For that reason, at that dates, at early 80s, we tried to finish every part of the operations in hospital and then give the baby to the family, because they didn't like colostomy. But now the change is changed, but this is just a historical remark.
Thanks for that remark. I think a lot of education is needed, and we can help in doing that, create support systems and tell them this is the way and it is nothing unusual. That is how the baby has to grow. Yeah. So in Manila, there was a conference and we had a lot of presentations from Africa. They do not have pediatric surgeons at many places. So they need to teach the surgeons how to do a good colostomy. So they had made nice models for how to do a good colostomy with gloves, going from a cardboard and then taking it out, how to bring it together, how to make a flower or how to make a divided colostomy. And looking into literature with adults, they're now doing bioprinting of the colostomy so that they can cut the colostomy bag properly. So bioprinting models of a particular, this is for adults with malignancy with end colostomy. We can use that for some babies who have an end colostomy. So a 3D printed model of the patient's colostomy is made, and then a cutting is made out of that this is the exact cutting for your patient, and you can cut the colostomy bag in this manner so that there is no leak. So these are the advances that are going on, whereas back home in villages with poor patients, we tell them to use a thin muslin cloth that is quite thin. It allows sweat to go on either side and there is no excoriation, we tell them to cover that with coconut oil, which is a moisturizer and does not allow excoriation around the colostomy. So they can use that to cover the colostomy. They can cut small pieces and it's quite cheap. So they can just throw it off when it gets dirty, or if they want, they can wash it also. Those who can afford colostomy bags are definitely using colostomy bags. Yes, Alp? You're muted. Please unmute yourself.
Thank you. So I was just mentioning, I mean, we talked about collaboration with other colleagues and so on, and how they impacted on the development of pediatric surgery.
Mm-hmm.
I here just would like to acknowledge the support that stoma therapists are providing.
Mm-hmm.
And just for the viewers of this recording who may not be medical, when we talk about the colostomy or stoma, it's when the intestine is brought to the skin level and the abdominal wall, in conditions where perhaps there might be blockage below, distally, or downstream, and it's a life-saving operation. And but on the other side, it is when the end of the intestine is brought to the skin, and that obviously has potential complications that it needs to be managed carefully. Stoma therapists usually are from the nursing background, and they care for those openings, for those stomas, and it's a dedicated team of people. They train, and it's a long training process that it has. And stoma therapist colleagues' presence and education, as well as the developments in the colostomy bags, or the bags that are used, and other consumables, has revolutionized the care of these children. The stigma attached to having a child with a stoma is a big one, also in the African continent. And again, from the surgical point of view, we're also trying to potentially not do colostomies if we can avoid it, potentially not bring out the stomas, bring out the intestine to the skin if we can avoid it. But under certain circumstances, as I mentioned, it's a life-saving operation. And then if it can be cared for, and often it is temporary. So if it can be cared for during that period, as best as possible, at least the child has a reasonable or good quality of life. Thank you.
So yes,
Shilpa,
Hector? Yes.
in my country have two teams of with the malformation and Hirschsprung, one in the hospital and the other in the public center. The private exists the possibility of the private go the patient with the public centers. Have a team of maneuver the colostomy, and all colostomy have the release for pediatric surgeons. But the reality of my country is not the reality of South America. South America, in my country, the distance is short, but in the rest of the country of South America, I have mountains, desert, and the others. It's very difficult for the pediatric surgeon work in this instance, in these countries. I have idea in my country, the law about the law of specialty surgeries, surgeries. For you operate a children, you need have pediatric urologist or neurosurgery or children. The road for pediatric surgeons for a specialty of surgery in children is the law in the countries with exclusively the pediatric surgeon operate the children. It's no have other road.
Very difficult to manage in such scenarios. And you can imagine a newborn with no anal opening having to travel all the way to the doctor who's very far away with a distended abdomen. Do they have ambulances? How do they travel? Is there any ambulance facility?
Yes, no have problem, no have problem. Transportation, the distance are very short in the one city at the other city, but it's not the reality of South America.
Yeah.
My
South
country is
America, huge.
different.
Definitely. So since we are talking about newborns,
the newborns is transportation in ambulance specialty with the pediatrician and the other things in the ambulance no have problem with the transportation. The exist public system is very good. It's very good.
So since we are talking about newborns, we have touched upon anorectal malformation. That is a condition in which there is no anal opening. So the baby is born without an anal opening. When the bottom is looked for, by turning around the baby, there is no anal opening. If it is a girl, you may find a passage in the front from where some minor amount of stool is coming. If it is a boy, you may find some green spots within the urine. But if it's a boy, he needs an early colostomy. A girl who is passing meconium, that is the stool which comes out from a newborn, adequately from the front, can be delayed a little bit. But a boy needs an emergency surgery. Yes, Al?
Thanks so much for highlighting that, Shilpa. So I think the recognition of conditions is so important. And then a referral to somebody who's going to be able to deal with it. And the days like this, the 7th of April, Pediatric Surgery Day, the World Pediatric Surgery Day that we're promoting, and with it trying to raise awareness, is in a sense is going to make the biggest impact by raising awareness amongst both the colleagues as well as the public, so that the conditions that are out there that require the treatment by a specialist or a generalist is able to be picked up and recognized and diagnosed and referred. So that's one big component of it. And I think anorectal malformations that we've been very much spending our lives on is one of them, that we have seen so many missed not diagnosed, they just missed newborn borns and is born and discharged home and not getting the treatment that the baby deserves. That's one big component. And then the other big component is, of course, prevention. And we talked about trauma in the beginning very briefly. And the accident prevention is a major topic. And again, being pediatric surgeons and seeing the children, how devastating it is for children that goes through that motor vehicle accident, being able to prevent them happen is a big component of pediatric surgical advocacy work as well. So again, what I'm trying to highlight here is the public health side of pediatric surgery. As much as we would like to deal with the major congenital abnormalities and we have the solutions to them, often the public health side of pediatric surgery is equally important for us. Thank you.
Thank you. Yes, Cenk?
There is a rule in Turkey. Those pediatric surgeons who are graduating, completing their training program, they have to do at least 2 years obligatory duty in any cities in Turkey. We have 82 cities, so every city must have a pediatric surgeon. But unfortunately, not the facilities, the conditions are the same. But now, in these days, we have almost at least a couple of pediatric surgeons in every city. This is one issue. Another thing that Alp mentioned, I'm in the site visit committee of European pediatric surgery and European urology. I was very much surprised when I had the visit in Uppsala in Sweden. According to their trauma prevention program, in 1 year, at that year, there was no major traffic accidents related with children in Uppsala and Stockholm as well. There was no that, and no major, no major problem with the children as far as traffic accidents are concerned. This is very important, as I mentioned. The prevention is very much important. Thank you.
So since we are talking about newborns and identification of conditions, we've talked about anorectal malformation. The other condition is when the baby does not pass stool on day 1 of life. Even on day 2 of life, he does not pass stool. Even on day 3, this may go on to 5 days. And we need an enema or a wash to pass the first stool, and then continues to have constipation. So this is a condition known as Hirschsprungs disease, which also needs early identification and treatment by a pediatric surgeon. With that, we move to the front of the baby and we see for conditions in which there may be a bulge in the inguinal area. I would now request Professor Alp to tell us what is a hernia and how do the parents should look for it.
Thanks very much, Shilpa. So one of the most common conditions that a pediatric surgeon will face with, and one of the most commonly performed operations that we do is the inguinal hernia operation. So it is therefore an important topic for the public also to be aware of. The simple definition of inguinal hernia, when perhaps the parents and looking at the child or bathing the child, is that they will see a little bulge in the groin area that comes and goes. And that bulge in the groin area may also extend itself to lower down to the scrotum area too. So this bulge appearing should be already a red flag and requiring a physician, a pediatrician or a surgeon to see the child. It's when the intestine basically finds its way through a naturally occurring channel, which is supposed to close at birth, doesn't close, and intestine finds its way and comes out into the groin area. That's probably the simplest way of defining that. It needs to be repaired surgically because of the complications. There are numerous complications. We don't have to go through that, all of them now, but it can certainly cause for the intestine to get blocked and even become necrotic, gangrenous in that area. The surgery itself to prevent these complications happening is very simple. It's very well established today. But I think the key message here is that the surgery needs to be taking place sooner. It's not something that you can delay the surgery for months and for years, and it needs to be done soon, providing that there is no complication. If a complication due to hernia has happened already, if the intestine is gangrenous or threatened and so on, that requires an immediate emergency operation. So again, putting it back to the basics, any swelling in the groin area, any swelling in the scrotum in a male baby, and any swelling also in the females in the groin area is something that a doctor needs to see, to take precautions and refer to a surgeon if needed for surgery to be done.
Some laymen believe that it will get cured on its own. So the take-home message is that it needs surgery in 100% of the cases. If it is a hernia, it will never get all right on its own. The hydrocele, the hydrocele is a fluid collection which may resolve on its own, but the differentiation has to be done only by a pediatric surgeon. With that, I move to Professor Cenk. Please tell us if there is unequal scrotal swellings, or in other words, the gonad is absent. How do the parents look for it, and what is the treatment option?
You mean the gonads in the hernial sac?
The absence of gonad, that there is no gonad, undescended testes.
Okay. Well, first of all, we have to take a nice history, because to our impression and to my personal statistics, if the mother has some problem in her pregnancy during the first 2 months period, and if there is a progesterone therapy or if it's a artificial pregnancy, the incidence of the undescended testis is to our experience is maybe 10 times more than the normal pregnancies. In such conditions, after taking this history, generally, of course, we have an ultrasonography, but for the undescended testis, we wait at least 6 months for the migration of the testicles. But if the ultrasonography there is no gonad, so probably we can do the if the testicles are intra-abdominal position, we can make an early attempt probably. But to our statistics, real undescended testis, the malignancy incidence is not that much mentioned in the literature. For that reason, we have to talk about the family carefully. And we generally, if there is no gonad in the scrotum, we have to do the operation about a year. But if there is no gonad, we have to do laparoscopic procedure first, but before laparoscopy, we always make a careful examination during the anesthesiology, because some gonads can be easily held in this inguinal pouch with careful examination, and that period we can do inguinal approach. But if there is no testicle, if there is no testicle in the physical examination, laparoscopy should be the first attempt to be done. Pardon?
If it's a newborn, when should the parents visit a pediatric surgeon or a pediatric urologist? What time should they visit the doctor if they notice at home on day 5 of life?
It's important to give them the future of the disease. So I think it will be easier or the logical to get in touch with the family as early as possible, because we can tell the problems, we can tell the possible complications for the short time and long time, and we have to mention about if it's a palpable gonad. We have to mention about the testicle torsion, other things. So as soon as possible, I think we have to get in touch with the family.
Mm-hmm. So yesterday, a patient had come to me and the mother said that the baby was not passing urine from the tip and was passing from the undersurface, which she noticed only at 7 months age. Before that, she had never noticed. It is only when an aunt came into her house and saw that the urine is having a deviated path. So what is that condition known as, and when should the parents approach the doctor for that?
This is the problem that you mentioned is called Hypospadias. The general name is Hypospadias, but the problem with the babies, with the diaper, this is a general problem. Sometimes family cannot notice where the urine is coming from if the baby is under nappy. In such conditions, we want to see the baby, like in other conditions in neonates, as soon as possible, and we have to give the description of the disease, and we have to mention about the problems as far as urination or erection problems or the sexual relations in the future is mentioned, and we have to if it's coming from a area which ritual circumcision is made, we have to warn them not to do any circumcision. And generally, if it's no other congenital problems, we usually ask to operate the children between 6 months and 1 year of age. If the problem is a big problem, which needs at least 2 operations, so if the staged operation is needed, we have to deal at latest the first operation in 1 year of age. This is for the correction of the curvature that we call cordy, and the fixing of the skin problem. And the second operation should not be done more than 6-month period. So all the things have to be done in 1.5 years of age. This is for the memory, bad memory of the children, not to remember any genital operation. So we have to warn families in such issues. If it's a very minor hypospadias, if the hole is very close to the glands, this have to be discussed with the family as well, because in such conditions, sometimes operation may not be needed as well. So we have to make we have to inform the family about the different issues. But the severity of the disease is important. And in those days, I have to mention one more thing. When I was resident, early 80s, minor hypospadias was not considered a major problem. But as John Duckett told me, he was a legend in this area. When the videos and the pornographic publications on the area, females, girls have a much knowledge about the penis, shape of the penis of the boys. So after early 80s, many boys wanted to be operated for minor hypospadias as well, due to the criticisms of their girlfriends. So this is an important issue. For that reason, the aesthetics and normal-looking penis became a major issue after the mid-80s. This I have to mention this as well.
So you gave a very important message, like circumcision should not be done for any patient who does not have the opening, the urethral opening at the tip. Circumcision is removal of the foreskin, which is done for religious purpose in Muslim countries, and it is quite common. So if you are living in that country or you follow that religion and you're going for circumcision, please see that the urethral opening or from where the baby is passing urine is at the tip and not anywhere else. So with that, we move to neonatal jaundice. Sometimes babies have neonatal jaundice, which can get prolonged up to 3 weeks of age, and a condition known in which the biliary tract, that is the bile flow from the liver, is obstructed. Dr. Hector, can you tell us about that, please? You please unmute yourself. Unmute yourself. Your microphone is unmute yourself. Yeah.
Yes, sorry. In my country, the general pediatric surgeon released phimosis, cryptorchidea, etc. But the urologist exists the diplomature of pediatric urologist. This diplomature, I don't remember the name in English, diplomatura. Amadeo, ayúdame.
I think circumcision. Please unmute yourself. Unmute yourself.
It's the same, diplomature.
No, it's a certification.
Okay.
Certification, okay, certification. I don't remember. Certification. The certification of urologist is in the hospital, in the pediatric clinical. The surgeon, the pediatric surgeon, work with the urologist and formed with urologists with experience, with work with in my hospital, and formed the pediatric urologist. The pediatric urologist operate the phimosis, cryptorchidea, but the more surgeries are hypospadia and the other problems with urologists, pyeloplastia or the other things. But the more operate in phimosis, cryptorchidea is the general pediatric surgeon.
Okay.
The pediatric refer at the pediatric surgeon in the recién nacido, como es born, in the first 3 months, refer to the pediatric surgeon. And pediatric surgeon, in my case, I see the baby at the 6 months, at the 9 months. If the testicle is in the same seat, I operate in the 9 month or 1 year. But the testicle is descent, I prefer operate on the 1 year.
Okay. So what is the age? What is the age for religious circumcision in different countries?
In my country, the circumcision is in the diagnostic is phimosis now, 3 years, 3 years or more.
Okay.
3 years or more. 3 years or more. But in the no descended testis or difficult in the testis is in the channel, I release the laparoscopy and descend in 1 or 2 stage. But I prefer the 1 stage, if possible, fraction or the other techniques. But I prefer 1 stage laparoscopy.
Okay.
If it's possible.
If possible. Yes, you wanted to say something, Professor Zanotti?
Talking about the religious circumcision in Paraguay, we have 2 large communities, the Jews and the Muslims also, and almost everyone get a circumcision. But I found several times, well, not frequent, but a few times, Hypospadias that I recommended not to do the circumcision before before treating the hypospadias, even in those communities.
Mm-hmm.
That's all. But I was going to mention about the jaundice that you asked before.
Mm-hmm.
The one important thing that we must make aware of is that the jaundice is very common in newborns, but what we should look at is the jaundice that persists after 2 weeks or 3 weeks, or the jaundice that starts after 2 weeks.
Mm-hmm.
So we have to make aware that the neonatologist that the jaundice that persists after 3 weeks or 2 weeks, or the one starts after 2 weeks, we should look at biliary atresia, or at least to rule out the diagnosis of biliary atresia, or otherwise we will overlook many conditions that can be treated but too late. And in those cases, the prevention or early treatment is adequate, as we always say in many of the pediatric surgical conditions.
Mm-hmm.
The opportunistic or the right time to do the diagnosis and treatment.
That's very important. Welcome, Professor Horacio Alberto Questa. Please unmute yourself. You're muted. Unmute yourself.
Thank you.
We were talking about biliary atresia. Can you tell us about what is biliary atresia?
Happy day for all.
Yeah,
I think similar to Amadeo, but I believe in in Garrahan Hospital in Buenos Aires, Argentina, we always think about the importance of the acolia with scenes of biliary atresia. When a birth
White stool.
has acolia, is a scene very important of biliary atresia. With acolia, the patient will need a cholangiography immediately. Acolia is equal a cholangiography immediately. After we can discuss about the approach of cholangiography, is for minimally invasive or for open laparotomy, but always he needs a cholangiography.
So
cholangiography determine the disease.
We usually do per-operative cholangiography, but if there is biliary atresia and the gallbladder is atretic or absent, we are not able to do that, and that confirms the diagnosis of biliary atresia. Do you do a percutaneous cholangiography, or you do through the gallbladder only, like we do?
We do very important at the liver aspect.
From the liver, okay.
It's very, very important, the liver aspect. With the liver aspect is fibrotic, the diagnosis of biliary atresia is real. Is real. If when the gallbladder is atrophic, if it's possible the cholangiography, we perform the cholangiography. But if not, we begin the Kasai procedures. We begin the dissection of gallbladder and porta-hepatic.
Yes.
So is it common in your country, biliary atresia?
In Garrahan Hospital of Buenos Aires, Argentina, we had already 10 and 12 cases per year.
And what is the average?
One for month.
Okay. And what is the average age at which they present in your country? The median age, most common age of presentation.
Median age.
The common age of presentation.
Late. The diagnosis is late.
Late.
50 days. Average 50 days.
Yes, Al?
Thanks very much. I thought I'll just summarize it and I have heard and what we all know. I think, as you mentioned, this condition with biliary 3 is not present in the newborn. They're born with an absent biliary 3. It is a devastating disease. We're all aware of it. But the two things that I have heard again this afternoon from the colleagues is that the jaundice that carries on for more than 2 weeks is important, and we must check if there is a surgical cause for that. As we've also heard from Horacio, the pale stools is very important. So if it is there, it needs to be investigated, and the time is the essence again. So if we're talking about delayed presentation, if it's late for more than a month, it's already not good. If it's late for more than 2 months, if the baby is 2 months or older, it's also not very good. It's in fact not good at all. The reason we are saying that is that the surgery is needed for this condition, and I'm talking again for the public that is listening to us. And the earlier the surgery is done, the better the results, because if the surgery doesn't take place and or is not successful in certain circumstances, of course, particularly because of the delayed diagnosis, the only thing that helps these children is the liver transplantation, which is major undertaking, if it is available. And in many parts of the world, it's also not available. So I'll just summarize this again for the public that
Yeah,
is
definitely.
hearing us. Thank you.
Definitely. So if the baby has jaundice that lasts more than 15 days, if the color of the stool is white, from yellow it has turned to pale and then white, you should meet a pediatric surgeon urgently. The color of the urine is dark yellow. So this is a condition known as biliary atresia, which can cause liver failure. In India, we have the median age of presentation of 4 months. So if we get before 3 months, we think we are lucky. But still we carry on with the Kasai and save as many as possible. So I think we have discussed many conditions today. We have discussed about hernia. We've discussed about undescended testes. We have discussed about anorectal malformation. We've talked about hypospadias, and we've talked about biliary atresia. All these conditions are congenital conditions which present either in the newborn phase, and biliary atresia can present at 3 weeks of age. So please watch out your baby for these conditions and reach the doctor. I would now request Professor Alp to please wind up this session today, and then we can join back again tomorrow with a new session.
Thank you very much, and thanks very much to Professor Sharma for organizing this event, and also huge thanks to the WOFAPS colleagues at the WOFAPS and the executive committee and the members for making this possible. The 7th of April is the World Pediatric Surgery Day. It is really to raise awareness around the issues that are, as far as I'm concerned, public health issues, children's surgery related issues. As we have seen today, there are differences in different parts of the world, but as also we've seen today, the colleagues from Asia, from Latin America, from Europe, Turkey, from Africa, we can get together so easily, and we are getting together regularly, and we are having these discussions regularly to find the best ways to manage the children with surgical diseases. And as again, in the beginning, I mentioned the goal of WOFAPS, the goal of pediatric surgeons, is to improve the outcomes of the surgical conditions in children, and ultimately give children a life that is many decades ahead of themselves at the time that they're having the surgery. So thanks again to all the colleagues for joining us, and thanks very much for Professor Sharma also organizing this afternoon's event, and we hope to see you again tomorrow. Thank you.
Thank you so much.
Bye. Very laudable, Shilpa, and congratulations to all. And congratulations to you because of the pushing of this 7th of April. Good, very good.
I think it was a nice session. Thank you, everybody. Thank you so much. Thank you.
Congratulations
to everyone. We end this
Have a
session.
nice day. Have a nice day.
Thank you. Bye.